So today we will be talking about myeloid disorders. Basically, I'll try to divide it. First, when we look at the stem cells progressing to develop lymphoid progenitor cells and myeloid progenitor cells. If we look at each stem cell line, where the end product, any abnormalities, any of these lines will develop the malignancy corresponding or the abnormality related to the pathology related to it. So for lymphoid, there's a T cell or B cell, so I can have a T cell lymphoma or B cell lymphoma. While the myeloid progenitor cells can end up developing platelets, monocytes, neutrophils, basophils, eosinophils, or collectively known as granulocyte. Any of these cells can develop normality or malignancy. So the myeloid disorders first will have the acute myeloid leukemia, which is in the immature cells or blast. And then we'll have the myeloproliferative neoplasm with proliferation. We have either too many red blood cells, develop polycythemia. Too many platelets will have essential thrombocytosis. Too many granulocytes basically develop chronic myeloid leukemia or malignant leukemia. And then there's an entity which has either both myeloproliferative plus the myelodysplastic. Too many monocytes, but also have dysplastic features of the myeloid. This is CMML, chronic myelomonocytic leukemia. And then not enough myeloid cells, and there are cytopenias, and then also bone marrow failure with dysplasia. This is myelodysplastic syndrome. From number 2 to 4, all these disorders can eventually develop acute myeloid leukemia. Now, in the other side, from the lymphoid progenitor cells, you can have ALL in the immature or the lymphoid proliferative disorders that are mature, like CLL or the lymphomas. And then also we have the plasma cell disorders or from monoclonal gammopathy all the way to multiple myeloma. Now, let's focus on the malignant myeloid disorders, okay? And first we start AML. So we'll cover AML and then the proliferative disorders and then the MDS. So the myeloid or lymphoid, we can look at them acute and chronic. AML, which is usually adults. ALL, pediatrics. CML, chronic myeloid leukemia, is a proliferative disease. And then we have the other spectrum for the lymphoid is chronic lymphocytic leukemia. Okay. Now, acute leukemia or AML versus ALL. Okay, AML would has myeloblasts, ALL would have lymphoblasts or lymphoid blasts. Usually, this is in pediatrics and the AML in adults. Okay, cause for the AML, it can be a de novo, meaning unknown development zone. It can be secondary, mainly chemotherapy exposures, having congenital syndromes, or myeloproliferative neoplasm or MDS prior to that. Presentation, okay. Those patients, they can usually present with cytopenia. So they have a low hemoglobin, fatigue, tiredness, and shortness of breath, feeling lightheadedness, having low platelets, bleeding them, having a low white blood cells, and infection. So depending on the cell line that's affected. Systemic sometimes also symptoms. Basically, too many white blood cells causing glucostasis, meaning decreased flow of the blood flow in the vessels. DIC or tumor lysis, to high counts of breaking and to tumor lysis. It can be due to infiltration in the organ. Okay, the diagnosis of AML, the main hallmark is, what I said, the peripheral smear. We have cytopenias, but also having a blast counts more than 20% in the bone marrow. That's the hallmark diagnosis. And then having the Auer rods. Remember, Auer rod differentiating with the ALL, okay, the flow cytometry finding in their molecular tests, myeloid neoplasms, Auer rods. It's almost never normal, the Auer rods, okay? These are rods seen on the blast, okay, indication of myeloid disorder. If there's a patient having an Auer rod blast and having issues with bleeding, always think about APL. APL, which is type of AML, is acute prolonged myelocytic leukemia, and those patients, they have on the molecular testing, the genetic testing, translocation 15, 17, we have to keep in mind, it's the most curable type of AML. But you have to keep it, those patients will might lose them early if we don't start treatment very early because of DIC or bleeding. So that's why, remember what you need? ATRA. Remember, ATRA early on, you have to have ATRA. Now, acute leukemia can present with many emergencies, okay? Name two, the tumor lysis or leukostasis. Tumor lysis, meaning cell death is high or turnover of cells. What leads? Breaking cells leads to high potassium, high phosphorus, uric acid. All together can cause kidney problems, right? Low calcium. So this is what happened to lysis. And then the kidney problems, also seizures, and we know very well hyperkalemia can cause, yes, cardiac arrhythmias. Treatment, we have to fix these electrolytes. Manage the potassium, manage the electrolytes, hydration. Allopurinol helps. Resveratrol also helps. Used for patients who are acutely ill with acute kidney injury. Of course, the main way is to treat the disease, but also need to stabilize patients with this management first. Leukostasis, as we said, with AML, then ALL, also CML, very, very less likely to happen with CLL. And basically is a sticky blast, decreasing the flow. So any organ that has decreased flow leads to damage of that organ. So the lungs have an hypoxia, the brain have confusion, okay? So high white counts, always worry about that. Treatment of those patients with leukostasis, fluid hydration, cytoreductive therapy with hydroxyurea urgently, but other thing can be done is plasmapheresis, okay? Tumor lysis prophylaxis, okay? And be very cautious with transfusions. So the other thing is DIC. APL, you have to remember ATRA, no APL. Keep transfusion as needed, fresh frozen plasma, and of course you have to get treatment started. The same thing for APL, have to remember the ATRA, and then transfusions or fibrinogen and other transfusion support. Cytopenias, the patients having no bleeding, then platelets start at 10. There is a bleeding, platelets are 50 and higher, like doctors. Febrile neutropenia is basically having an infection or have fever with neutrophils are less than 1. Those patients need IV antibiotics. This can be discussed separately. Extensive thrombosis as well can happen because malignancy increases the risk. Now, treatment of ALL. Sorry, treatment of AML. We'll divide it into two. First, if we're talking about AML, and we look at them, are they young and fit or are they frail and old? So if they're young and fit, it's induction treatment, get a remission, and then once remission, depending on the risk group, we can do consolidation or we can do allogeneic stem cell transplant for the high risk, okay? For the not fit patients, the treatment will be basically less intensive chemotherapy. Now, patients with APL, they're treated definitely differently. The most important thing, L-transuranic acid. The sooner you start, the more likely you save those patients from bleeding. The one thing you need to remember and be careful of is the differentiation of APL, okay? When it starts, so you might have a worsening of infiltration in the lungs, so trouble breathing, so we have to manage those with the steroids. Coagulopathy for those patients, we have to try to reverse it with transfusion support. And always, we said ATRA start, and then those patients, arsenic plus minus chemotherapy, depending on their group. So ALL, as those patients, we said young kids, the treatment, induction chemo, then consolidation, intensification, and then maintenance. The whole treatment of those patients can be very long, and it can take up to 2 years or longer. Now, we have to remember ALL is more likely to develop or have CNS disease than for involvement, so they need always evaluation. And also to consider that they're always part of these protocols is to have a CNS directed, either prophylactic or therapeutic treatment. Okay, now Moving on to this case, 59-year-old male presents with fatigue, night sweats, weight loss. He has no known past medical history, okay? Not in medication, he is a smoker, okay? Does not consume alcohol. His exam demonstrates no findings, but his hemoglobin was low, white counts are high, platelets are high, with white blood cell different showing a left shift. There's myeloma and metamyeloma, and there was a blast. Now, what of the following is the least likely diagnosis? Can this be metastasis cancer? Can this be CMML? Can be essential thrombocytosis, myelofibrosis, or MDS? Okay, so we have to put the whole picture together, and then we move on to the next. Let's have a look at these three myeloproliferative disorders, and then we'll decide which of the following is fitting this case. Now, myeloproliferative neoplasm, okay, is meaning too many mature myeloid cells, okay. The CML, and when those patients that would have too many granulocytes, we have to remember that those patients, they have Philadelphia chromosome positive, and polycythemia rubra vera, which is too many red blood cells, essential thrombocytosis, too many platelets, and then myelofibrosis is too much fibrosis in the bone marrow. And basically, for those patients, the mutation is they don't have the Philadelphia chromosome, but they might have the JAK2, or also the mutation to consider is CALR mutation. It's about 30% of patients ET and primary myelofibrosis. Okay, let's take them one at a time. CML, chronic myeloid or myelogenous leukemia. As we said, this is too many granulocytes. Those patients, they have Philadelphia chromosome positive or 922 translocation. This can be chronic phase, accelerated phase, or blastic phase. So chronic phase, those patients that will have high white counts, have a splenomegaly, constitutional symptoms, blast would be less than 10%, okay? Those patient management is tyrosine kinase inhibitor, okay? Now, those patients nowadays, these treatments have been doing much better. Accelerated phase CML. The accelerated phase CML is basically a blast between 10 to 19. Remember, 20% higher is keeping with blastic or acute leukemia phase. Or having basophils more than 20%, presence of additional clones is possible. So those patients, they having counts worsen despite therapy. So treatment usually higher doses of TKI. The blast phase is CML more than 20%, and we treat those the same as AML with induction chemotherapy, but we add to that the tyrosine kinase inhibitor. Okay, we move on next to polycythemia vera, which is too many red blood cells, okay? And those patients, because too many red blood cells, they're having issue with pruritus, erythromelalgia, okay? Aquagenic, meaning water makes them pruritic, okay? Then those patients that would have arterial or venous thromboembolic events due to this effect blood flow from this increased blood cell mass. The diagnosis as having 3 major or 2 major or minor criteria. The major, most importantly, the high blood cell mass and basically having hypercellular neurophagy, and then having the JAK2 or JAK2 exon 12 mutation. Having or one of the minor, which is low serum lipoprotein. So those patients, when we see them, we divide them either low risk or high risk. The low risk group are less than 60, never have a thrombosis. The high risk are either having thrombosis in the past or higher than 60 of age. So simply to put it, low risk, aspirin plus phlebotomy. High risk, if they have thrombosis, then blood thinners, anticoagulation, if not aspirin, and then phlebotomy and cytoreductive therapy. First option, hydroxyurea. Remember, for pregnant ladies, interferon would be safer. Now, if patients do not tolerate the first-line therapy, upon increasing the dose, then we proceed with ruxolitinib with the JAK2 inhibitor. Okay. Now, we talked about too many granulocyte, too many red blood cells. Now we talk too many platelets. Now, having a 4 major criteria or 3 major and minor that sustain the platelets always high above 450. Bone marrow mature hyperreplicated megakaryocytes. We need to make sure there's no other diseases causing high platelets. And then we look at the molecular testing, which can be seen. And basically the minor, no reactive cause, because we can see with infections, inflammation, that high platelets. The risk basically depends on age and history of thrombosis in the past. How we treat, depending on the risk group. It can be only observation at very low risk, or it can be aspirin only. Intermediate risk, basically aspirin, and depending on the how high the platelets are, and the high risk is they will need cytoreductive therapy as hydroxyurea and aspirin. Okay. Now the third disease or fourth disease here we need to look at myeloid disorder is the myelofibrosis. Myelofibrosis is fibrosis in the marrow, myelofibrosis in the marrow. It can be primary or it can be secondary after the ET or PV. So those patients, the hallmark is to see a very large spleen. Those patients that would have a B symptoms, and then they might have cytopenias, having a leukoerythroplastic picture with a teardrop cell, red blood cells like a teardrop. Okay, and then 50% those patients that might have a Budd-Chiari syndrome, thrombosis. Diagnosis, of course, as we said, fibrosis is the most important. Having molecular testing that's positive JAK2 or CALR or PL mutations. And then we have to rule out that there's no other MPN or MDS. And the minor criteria is having anemia, having high LDH, having leukocytosis, polyp spleen, okay, leukoerythroplastic picture. Now, those patients, the risk stratification is the dynamic international prognosis scoring system. That's what we're following to determine. Low risk, those patients basic supportive care. High risk, depending on their age. If they have a good performance status, then we just do a transplant is an option. Patients who have a high-risk disease, but they are not a good performance status, then basically the JAK2 inhibitor would be best option for those patients and supportive care. Now, let's talk about the disease that is actually in between CMML, which is between myeloproliferative neoplasm and MDS. So the proliferation is on the monocytosis. Those patients, yes, they have a blast less than 20 because a blast more than 20 is acute leukemia, yes. And if there's dysplasia, they will be seen as well in the myeloid. And we have excluded other disease. So those patients, they're likely to progress to AML. Treatment, we need to treat as MDS if they have lots of dysplasia, or treat as MPN with a proliferation. Going back to our case, okay, so this patient's cytopenia, hemoglobin 105, leukocytosis, high platelets. They have also blasts, okay? So, and several nucleated blood cells are seen. So this is a leukoerythroplastic picture. What is the least likely? So let's look at them one by one. So metastatic cancer, it can give you in the bone marrow fibrosis. It can stress your bone marrow. It can make the bone marrow produce teardrop cells and almost looking like erythroplastic picture, okay? Chronic myelomonocytic leukemia, we just talked about this disease as well. It can give you MDS and MPN, like there's some proliferation, okay? And then having a blast, so it's possible. Myelofibrosis, yes, it can have thrombocytosis, can have leukocytosis, also anemia, seen on the blast, or seen, okay? Essential thrombocytosis was basically, as we mentioned, only elevated platelet counts, okay, sustained elevated platelet counts. This is why this is the least likely, okay? So, and if we have polycythemia vera as well instead, it could be also least likely because patients have anemia, okay? Now, let's move on to another question here to introduce the next topic that we will review together. A 63-year-old female with a history of ER/PR positive breast cancer treated with chemotherapy. Okay, so a patient had chemotherapy before, okay, and radiation, 2 years. Prior present with fatigue, worsening, exercise capacity, including dyspnea or exertion, and overall decreased functional status. She continues on hormonal therapy currently. Her exam demonstrates no breast masses and no localized bony pain. So basically, had these symptoms, also looking now to try to find a patient have a relapse of their breast cancer. When they're mentioning about the bone and breast masses. Looks pale. Okay, gives me an idea. Maybe they have anemia. Grade 3 to 6 systolic ejection murmur. Well, anemia can cause flow systolic murmur. Can be heard over the left sternum and no pertinent exam findings. Her blood shows, oh, look, hemoglobin is very low. Now, this is very important to look at MCV, 108. This is very high. So macrocytosis is actually one of the findings that we need to pay attention to in malignancy. See, white counts, very low. Oh, let's look at the ANC, 0.8. Platelets 75. So basically, this patient across the board has cytopenias. The blood film showing hypolipided neutrophil. So when the neutrophils hypolipided, this is a dysplastic feature striping with poor granulation. It's kind of pale white blood cells. What is the most likely cause of patient's presentation? Acute myeloid leukemia. Can this be acute myeloid leukemia? Let's see more. Myelofibrosis. Myelodysplastic syndrome. Can this be metastasis, cancer to the bone? Vitamin B deficiency, B12 deficiency. So let's go into the next topic and then we'll decide afterward. So myelodysplastic syndrome. So pathophysiology is basically clonal disease involving a clone, dysplastic cells, and dysfunctional blood cells. So these patients have a risk of progression to acute myeloid leukemia. This is what we call what? Secondary AML then, okay? So the MDS, this can be primary or secondary. Secondary due to bone marrow damage, DNA damage of bone marrow due to chemotherapy, due to radiations. So definition, patients having dysplasia, meaning a dysmorphic cells, then having cytopenias, an abnormal karyotype, or myeloblasts higher, the blasts in the marrow are higher. Usually we see it in older folks having cytopenias, having hypogranular hypolipided neutrophils or platelets or macrocytosis, as we said, decreased reticulocytes. Why? Because the bone marrow is not functioning properly. It's not producing something. The risk international prognostic scoring system and revised. This is how we stratify those patients, which is basically we're looking at the cytopenias, we're looking at the blasts in the marrow, cytogenetics. Those are help us to decide those patients what risk group they are. So bone marrow is the most diagnostic feature, a gold standard diagnosis. And sometimes with hyperciliary marrow, that's usually how we see it. Ring sideroblast or possible dysplasia more than 10%, and blast less than 20. Why? If they are more than 20, then this is acute myeloid leukemia. So sometimes there are things cause findings similar to MDS in the marrow, B12 deficiency, and alcohol, okay, zinc toxicity, having history exposure to some medications, immunosuppressant like methotrexate and thiopurine. So, according to the IPSS score, revised IPSS, if they're low risk, might be just only supportive care, but also have what we call a 5q minus deletion. We treat those patients with lenalidomide. Okay, high risk disease, we can still consider as a supportive care, but stem cell transplant is the best for patients who are young and fit. If they're not, then what we do is hypomethylating agent, DNA, like azacitidine or decitabine. Now, when we go back to the case, okay, so we said this patient has cytopenias, okay, and basically demonstrating this dysplasia in the neutrophils, okay, the most likely diagnosis is myelodysplastic syndrome. Now, why is not AML? Okay, consistent with second given history of radiation and the chemotherapy, that's most numbers to. Number two, the pancytopenia we said. And number three is the dysplasia we see on the cells. Okay. Now, myelofibrosis would usually have, as we said, leukoerythroplastic picture. Some blasts, some teardrop cells, also nucleated blood cells. Now, there is no blast count seen on the peripheral blood, makes it less likely to be AML. Although, if we wait for this patient a little bit longer, it can come with AML. Okay, but here the MDS is more likely than AML. Okay, so these are the myeloid disorder between the proliferative and also acute myeloid leukemia and the MDS. I hope you guys will find this very useful.